So we ended with Medicare being born. It is now almost 50 years old. And even when it was born, the policymakers who invented it thought, well, we know things are going to change over time. They should. And when you start out with a program, it's never going to be perfect. And it has indeed changed quite a bit over time. And by 1972, it had gotten quite expensive. At the same time, they decided they should add under 65 disabled and those with end-stage kidney disease. Don't ask me why, but it is a little bit odd that they added end-stage renal disease and not every other long-term chronic illness that people got, but that got added to Medicare for the under 65 population. In 1982, they added the hospice benefit. In 1988, Congress actually added catastrophic coverage because, as I'll explain in a minute, Medicare does not limit the out-of-pocket amount you pay in copays, deductibles, and premiums. So back in 1988, that was recognized, and Congress passed a bill to create an out-of-pocket limit as well as to cover prescription drugs, which had been left out of traditional Medicare. But it got repealed a year later, and I'll explain why in a minute. By 2003, they did put back in the prescription drug coverage, which is now Medicare Part D. So why did Medicare catastrophic coverage along with prescription drug coverage get repealed 1 year after it got passed? And the main reason was, well, two main reasons. One was that the idea of financing it was going to be 100% on the beneficiary, which wasn't very popular. And as you can see from the other Part A and B slides, that was not the way any of the other parts of Medicare have been financed. But the other reason is most people have catastrophic coverage now. They buy it privately in what's called the Medigap market. And this is a slide of where people are covered today. There's multiple ways to get that coverage. Most people get it either from their employer paying a premium for private coverage for catastrophic care, or buying their own private Medigap policy for private sector care. It covers copays, deductibles, out-of-pocket limits, those kinds of things. Some people are covered for these catastrophic costs through Medicaid, because they're income eligible. And then others got into Medicare Advantage plans. That's Medicare Part C, which will be coming up later in another talk. So only about 7% of the population have no catastrophic coverage, and it wasn't enough of a political group to be able to impose this cost on the rest of the beneficiary population. The catastrophic coverage part got repealed, and then it took several years to get drug coverage put back in. Other changes in Medicare over the last 50 years were changes in the way providers got paid. As I mentioned, it was very expensive to pay cost and usual customary reasonable charges. So in 1972, Congress authorized the concept of capitation payment as opposed to cost. They didn't really make it fully operational for many years because actually we didn't know how to pay capitation costs for elderly people for many years. Major change, it became operational in 85, but not many people were in managed care capitated plans until 97 and then 2003 when they had other major changes. In 1984, there was a major change in the way hospitals were paid for inpatient care. They changed to what's called the diagnosis-related group method, DRGs, for hospital care, which instead of paying cost, says we're going to pay you really kind of the average national cost to take care of your condition. So there are over probably 500 DRGs out there now. There were originally 300 or 400. And they bundled together all of the payments for a particular episode of acute care. In 1992, Congress finally got the nerve to take on the doctors and put in resource-based relative value units for physician services, which is trying to measure how physicians' time and effort and stress, how much of that goes into each service. It was a massive undertaking, but they came out with a relative value system in 92 that many private sector payers also use as the basis for payment. And then in 1997 and 99, Congress implemented laws that require prospective payment for all the post-acute providers. And we'll talk a little bit more about that in a few minutes. One of the things you notice about these different provider payment limits is that they're great at reducing the rate of cost in the sector that they are targeted at. But what tends to happen is that costs go way up in the other sectors. So for instance, you can see that the DRGs in 1984 make the blue line, the hospitalization line, that's a rate of growth. That goes down from somewhere between 10 and 20% per year growth. It heads down towards 5 to 10% per year growth in the period after the DRG passes. But meanwhile, the post-acute sector explodes. The rate of growth in skilled nursing and in home care and in long-term care and rehabilitation that rate of growth explodes after the inpatient acute piece gets contained. So it's a bit of that whack-a-mole problem of you whack the mole in one part of the yard and he pops up in another part of the yard. But you see the relative value system then turns around and contains the MD, the red line. It starts to reduce its rate of growth after the relative value system comes in 92. But the post-acute sector continues to be out of control until Congress passed the prospective payment systems in 02 and 03. It's very challenging to contain the cost of Medicare, particularly when you're doing it one provider or type of service at a time. Some of the other policy changes were to put caps early on and try to get hospitals ready for the DRGs. But the couple I want to mention that are still in play today, 1997, the sustainable growth rate limit on physician fees, or really all Part B expenditures or some. That's still in play, and we'll talk about that in a minute. And then in 2003, Congress passed this notion that Medicare should only 45% of Medicare financing should come from the general treasury, the general revenue. And we'll talk more about that in a minute too. So these are some of the changes that happen over a 50-year period. Sustainable growth rate is this notion that physicians, the rate of growth in physician payments will not exceed the rate of growth per capita in the general economy. And what this chart shows you is that the physicians did pretty well at keeping their target growth rates below the rate of growth in the economy until the economy tanked in around 01. And then they start exceeding the rate of growth in the economy and have violated the rate of the growth in the economy ever since. Most of the reason for the rate of growth in the economy has been volume, the rate of growth in physician costs has been volume related. So it's that physicians, when they get constrained on how much they can charge, or how much they get paid really, they start to do more. And this chart shows you that they are doing most of the rate of growth. Physician expenditures have gone more than 70% since 2000. Most of that is because of increases in the amount of services delivered to the beneficiary on a per capita basis. However, Congress, even though it passed the law and says we're going to limit physician rates of growth, they don't implement it. And what that does is it makes the lack of implementation, the cost of that get loaded into the future years of rate reduction. So what you see in this chart is that Congress, only in 2002 does Congress actually allow the physicians' rates to go down. And from then on, they just pretty much freeze them, even though they should be making them go down every one of those years. And what that means is, in the future years, all the rates cuts they didn't take get put into future years. So for instance, 2014, it looks like they're supposed to have a 25% rate reduction. They won't do that. Congress won't do that. But they have to get out of this some way, and they haven't figured out how to do that yet. Very hard to fix because it's a $20 billion not taking the cost reductions bill. And these get projected forward by 10 years, it's now down to a $139 billion price tag based on current rates of growth, which is actually better than it was a few years ago. But it also, if you allow those kind of rate increases to stay in place, it affects the Part B premium, which is already getting pretty expensive, which we'll see, and it affects Medicare Advantage premium. So those rates of growth all make everything else much more expensive. Anyway, so we're 50 years out. What have we achieved in 50 years? And what this talks about is what's changed for the elderly. And what you see is there's a higher percentage of the population is elderly, which makes it obviously a little less affordable. It's not much different in terms of the proportion of people who have disability between before Medicare and now, but what we do see is that the rates of death per thousand have gone down in the different age groups that are in Medicare. So people are living longer, not necessarily because of Medicare, but they are living longer. And what we do see also is that, of course, many, many more people have insurance. So before Medicare, only 54% of people over 65 had hospital insurance, 46% had something kind of insurance for physicians. And if you weren't actually working in over 65, only a third of people, a little over a third of people had any kind of insurance. Now, almost 100%, 98.2% of elders have insurance. However, the out-of-pocket expenditure still remains quite high. You can see it was around 10% back before Medicare passed. And what happened was the hospitals actually ate the difference. They took a lot more free care rather than chasing elderly who didn't have money. Now it's about 5.4% out of pocket, but if you count in premiums, we're up to around 16% of premium of income is being paid out of pocket. And healthcare, as you can see, as a percentage of gross domestic product, has exploded, has tripled over this period. Before Medicare, it was 5.9%, and it is now 17.6%. So a huge increase in the expenditures on healthcare as a percentage of our economy.